May I welcome members, officers, and our visitors for today after our summer break. And could I also welcome those who are watching this on YouTube? And I think we have quite a number this morning that will be logged into this and watching what happens at this morning's meeting. So welcome everybody, and anybody who feels a little warm, particularly the men, if you feel like removing your jacket, that is fine by me. All right. Some have already done it. They're looking at me. Right. So virtually, this meeting is just one item, as has been pointed out. So before we move to that, can I have apologies, please, for this morning? Oh, I'm sorry. You're over there. Good morning, Sarah.
Sorry, we have apologies from Councillor Steve Carr for other reasons, and Councillor Purdy Horan is here substituting.
Thank you very much. And do we have declarations of interest, please? Let's go to the disclosable pecuniary first. Yes, Councillor McGrath?
My daughter's training to be a nurse.
Right. Vice Chairman?
My husband's a community staff nurse.
Thank you. And I have a declaration too because my daughter works at QMC. Any private interests, please? No? Right. Minutes of the last meeting. Do I have approval to sign them? Everybody's happy with them? Good. So we'll move on to Newark urgent care. And I think this is why we have several people watching us this morning, because I can assure you there is a lot of interest in Newark regarding this proposal today. We have people here, people we know very well, such as Lucy and Alex, and we have Dave Briggs, is that you? Who's the medical director for the Integrated Care Board, and Ben Owens, who's the consultant in emergency medicine at Sherwood Forest Hospital Trust, and Dr. Bartholomew's, who's clinical director at Mid Nottinghamshire Place-Based Partnerships. Before we start the meeting and I set out the scene of why we're here, I would like to say that the Vice Chairman and myself, approximately 2 weeks ago, I'm not quite sure of the date, we made a visit to Newark Hospital so that we were aware of what we were really discussing this morning. And I have to say, anyone on this committee who would like to visit Newark Hospital, I'm sure Alex would be more than willing to let people go round. We arrived, and I have to say we were given an extremely warm welcome. We were met by David Ainsworth, the CEO at Sherwood Forest Hospitals, and Yvonne, who is the matron of Newark Hospital. They were extremely warm and, of course, gave us a coffee first. And off we went around the hospital. And I would say we didn't leave a moment before 2 o'clock, did we? We were taken into the new modular theatre that has been built. And to say it's as large as this room is no exaggeration. It is huge. You could have a summer ball in there, I think. But it was very interesting to see the new theatre and the anaesthetic room, the room that you're taken to for recovery, and then they have linked this building to the main part of the hospital so that after an operation you can be wheeled back to the hospital. It was very, very impressive, I have to say, and our visitors from the Integrated Care Board will be giving us those sort of advantages of what they're doing. And the fact that they have two little side rooms, which when you go onto a ward, there are often two little side rooms where they take you in to take some blood or whatever. They've converted two of those to a small theatre. So small operations, I would think, like mole removals or whatever, can be done there. So people don't have to go into the big theatre and take time. But our visitors will explain all that. But suffice to say that as far as Newark Hospital is concerned, I feel very safe in it. It's an efficient hospital. The staff are very pleasant. And whereas you might go into a big hospital into the urgent care, you still go into urgent care and see a fair few number of people. But it is amazing how quickly they get you through it and you find yourself going back home. Not as long as you would have been had you gone to one of the bigger hospitals. But the reason this comes before us this morning is because, as members will know, we've had several extensions to the temporary night openings, which members have been very concerned about, as have I. But the NUH people will tell us why they've had to make these decisions. And for those of you who are not aware, the Newark bus to King's Mill is, to say the least, not very regular, if it's regular at all. And therefore anybody trying to get to King's Mill for any diagnostic tests have a difficulty if they haven't got a friend or somebody to take them, if they don't drive themselves. So to me, I've been asking for services to be brought to save people this agony of going over to King's Mill. And this is what's going to be presented today. And we're also going to have their reasons why they aren't able to open the urgent care overnight. So that's all I'm going to say now. I'll come back later. But I'm going to hand over, is it to you, Lucy, first? Fine. So we'll hand over to Lucy, who will have all the information. Thank you, Lucy.
Thank you very much, Chair, and thank you for that introduction. So just to remind colleagues, the Integrated Care Board's responsibility is to plan services and allocate resources to meet the needs of all of our populations in Nottingham and Nottinghamshire. And we're here today to particularly talk about meeting the needs of the Newark population. And as the Chair has said, we've been to talk to you over the last 3 years about changes that we've made to the urgent treatment centre under our emergency powers. And when I last visited you, you requested that we come back to you as soon as we possibly can with our settled proposal for the future of the urgent treatment centre, and that we put that in the context of the future of Newark Hospital, which the Chair has started to outline. And that's what we're here to do today. So I'm just going to introduce my colleagues who will take you through the content, but just a few things I want to say to you up front. As an Integrated Care Board, I do want to put on the record that we are absolutely committed to provide high quality, sustainable services to the Newark population and support Sherwood Forest Hospital's Trust, who provides services from the hospital, to deliver our shared vision that Newark Hospital is a valued and vibrant community asset for Newark. That commitment does not waver, and in fact it is growing. We truly believe that Newark Hospital is an important and vital part of our health and care landscape in the Newark area, and we do recognise that local residents really value being able to get access to the care they need close to where they live. We are absolutely committed to maintaining a safe and sustainable urgent treatment centre at Newark Hospital. And I think this will come up through our discussion, we are talking about urgent care today. We're not talking about emergency care, which is provided for the populations of Newark from Kings Mill or QMC. But we are absolutely committed to maintaining a safe and sustainable urgent treatment centre at Newark, and also to ensuring that the urgent treatment centre continues to operate at least in line with the opening hours required from the national specification for urgent treatment centres, which is 12 hours. We currently open 13. So together with Sherwood Forest Hospitals Trust, who run Newark Hospital, we do want to hear from local residents about their experience of using the urgent treatment centre, which the Chair has kindly introduced. And in particular, we want to know whether the current opening hours are suitable, or if there could be a different way to spread the opening hours over the day. We also want to check that other ways that you access urgent care overnight, particularly, are working as we expect them to, and we will talk about that. Because with that entire network of urgent care services that we can offer to the population of Newark, we believe that we can support the local population's needs. But clearly, we're extremely keen to hear from you. So I'm going to hand over to Ben, I think, who's now going to talk about Newark Hospital as that asset.
Thank you. So my name is Ben Owens. I'm one of the emergency medicine or A&E consultants. I'm also the divisional lead for urgent care, which covers Newark Hospital as well for Sherwood Forest. Just a bit about Newark Hospital and the advancements that are going on there. We're doing more diagnostic tests, treatments, procedures, operations than we've done before. We're absolutely committed, as Lucy has said, around improving the services there. Recent ones, so breast cancer one-stop service in one day, gynecological procedures, hip and knee surgery, as you say, the new operating theatre suite, also the endoscopy suite for camera investigations, a new CT scanner, and a new hearing booth, and parking for staff and visitors as well. So lots of things going on, further plans to do more things to improve processes for patients. And we're also working a lot with local organisations, Derbyshire County Council, the rider NHS services in the community as well, to try and improve services future as we go forward.
Thanks, Ben. Thank you, colleagues. So I'm Karan Bartholomew. I'm a GP. I'm the clinical director for Midnight Space-Based Partnership. I have been a GP in Newark for about 7 years. I'm currently a GP partner at Abbey Medical Group in Ravenshead and Blidworth. Just to reiterate, as Lucy said before, what we're talking about is about urgent care. And just for awareness, urgent care is different, and urgent care is for non-life-threatening urgent illnesses or accidents which needs urgent attention. This is different from emergency care, which is emergency accidents or illnesses which needs immediate treatment via A&E or 999. So we are committed to provide high quality, safe and sustainable urgent care services for Newark and the surrounding areas. The UTC, or the Urgent Treatment Centre at Newark Hospital, will continue to be a key element of provision of urgent care services, along with NHS 111, GPs appointments, pharmacy, and out-of-hours access. The current UTC delivers everything that the national NHS specification for UTC is required. As we mentioned before, with regards to emergency care, Newark residents will continue to have access to emergency care services via 999 and accident and emergency services. With Newark Hospital, as Ben has just mentioned, a lot has been done to improve services and provide more care closer to home. I won't go through that again. And the work is in line with our overall ambition for people to live longer and healthier lives. Access to urgent care system or urgent care can be seen at all parts of the urgent care system, in pharmacies, GP practices and through NHS 111. Most of you will be aware many pharmacies across Nottinghamshire are now offering clinical advice and treatment directly through their community pharmacies instead of needing to go and see their own GP. Within Newark, already 7 pharmacies provide this service, which includes providing advice and treatment for a variety of minor illnesses like water infections, skin infections, minor respiratory tract infections. With regards to urgent care access with general practice, GP appointments has increased, and when we look at the overall numbers since 2019, it's roughly about 3.8%, and the same day appointments have increased by 7%, and pre-bookable appointments by 2%. So this is access to general practice in and around Newark. In terms of, we are working with GP practices with regards to phone lights and their appointment system to improve access. Now, Newark GPs outside the core opening hours will also have access to out of hours access, so they can't have access to a GP outside the core opening hours for general practice. Something which I would also, as a GP, what we have seen over the past 5 years is the wider range of workforce within general practice. Over the last 4-5 years, through the development of what we call primary care networks, we have a wider range of clinical staff who are able to deal with urgent care. For example, physiotherapists or first contact practitioners are able to deal with urgent musculoskeletal problems, knocks, sprains, knees, muscle injuries. Likewise, we have mental health practitioners who are able to address mental health concerns. Lots of practices now have advanced nurse practitioners who are able to treat minor illnesses, minor injuries, and you can see how that has contributed to the improved access to primary care in and around Newark, but not only in Newark, across Nottinghamshire and nationally. With regards to accessing urgent care, using 111 has been the common way, and it has increased significantly since 2019. We have seen call volumes through 111 go above 50%. This is keeping with what's happening nationally. And what's more important is the 111 now is a much more enhanced service. They are able to provide clinical advice. Not only that, they can now directly book appointments into a GP practice. So from a patient point of view, you don't have to call back your GP and explain everything over and again. Plus, it improves patient experience, plus faster access. So that's a significant change, and I see that in my practice. It's common practice in all surgeries. So therefore, that gives you an overview of the urgent care access in and around Newark, and which is similar to other parts of the county as well. Thank you.
Thank you. Good to see you all. So, the Urgent Treatment Centre, since the pandemic, has been open from 9 a.m. to 10 p.m. The reason why we made that difficult decision over the COVID pandemic to reduce the hours on a temporary basis was to ensure we had safe, effective staffing that was robust. And when you went there to the Urgent Treatment Centre, it would always be open. Prior to the COVID pandemic, we found of occasions we couldn't staff it effectively, and it meant the unit closed without much notice, and that isn't great. If you've travelled all the way to the Newark Urgent Treatment Centre and it's unavoidably not open, that's not a great experience, and we wanted to avoid that over the pandemic. Since we've been in the pandemic, we've been able to look at what the reality, what it's meant for the people of Newark. And the Newark Urgent Treatment Centre is a very well used resource, very well used. 100,000 people use the Urgent Treatment Centre every year, big numbers, very highly thought of service. The vast majority of that activity is in daytime opening hours, with, prior to COVID, very small numbers being used overnight, one person per hour attending with the sorts of conditions that the unit is set up to deal with. We looked at what happened to patients, or have happened to patients, since the temporary closure has been in place, and we've found no evidence of harm. What we have in fact found is that people are using the daytime hours more frequently. and the sorts of conditions that the unit can deal with, that's not surprising. So less complex, still important condition, but less complex, normally can wait until the daytime hours to be dealt with, and that is indeed what we've found looking at the data we have looked to today. There has been some additional benefits from the reduction in hours. We've been able to make sure the skill mix is better. We've been able to look at increasing the number of people working in the daytime hours from the staff base that are currently delivering the care at the unit. And we've made sure that despite there being increased activity, the waits to be seen and the quality of service has actually improved with the new hours. So there has been some benefits of the temporary reduction of hours. When we are thinking through the future opening hours in the nighttime period, the challenges that we faced prior to COVID, during COVID, and now are quite similar. The staff who are competent and able to deliver that service are still in very much demand. And it is going to be and would be challenging to have reliable staffing overnight going forward. That challenge still remains. So we do need to think through the people of Newark with this unit. And there is an important consideration here that perhaps hasn't quite come out yet. The vast majority of overnight contacts with the healthcare service are for emergency or for complex problems. We have stepped up a big urgent community response service that links into 111 and to the out-of-hours general practice, which is for those citizens and those residents and those people in the area who have more complex needs, more complex care requirements. And that service over the Notts and Nottingham area has increased from 400 contacts to 1,200 contacts using the 111 and out-of-hours service that we've described. So if you are older and frail or young and frail, that service is still there, and that service is really important because it represents some of our most vulnerable people, and the service that they need to keep them out of hospital in the first place. And just to be clear, that's not the sort of service that the new urgent treatment centre can and should offer. That's an offer from primary care 111 and the urgent community response service. That's not denying the importance of the UCR, very important asset to the people of Newark, but the majority of the activity and the majority of presentations to the urgent treatment centre is in the daytime hours, which is why we want to speak about what the best fit of those hours would be for the people of Newark. So if I just hand over, I think it's back to Lucy, isn't it?
Dave, thank you. So my clinical colleagues have set out their programme of investment in Newark Hospital overall. As we say, it's a vibrant and growing facility that we're really proud of and will want to continue to see growing. But Dr. Briggs has also clearly outlined why we believe that the daytime hours are the best model for us to be using at the UTC. But we want to check that, and that's partly why we're here today, and why we're also live listening to local residents on two specific topics. We want to understand whether those current opening hours are suitable, or if there could be a different way, as Dr. Briggs has said, to sort of spread them across that kind of daytime period. Might it be more helpful for them to be open slightly earlier and therefore closing a little bit earlier, perhaps people who might need to come before work, or is there something more valuable about actually let's do it a little bit later in the day and perhaps it's an after school visit that that families might find more useful. So we want to understand how that balance might sit. And then secondly, we're really keen to hear from people about their experience of the general mix of out-of-hours urgent care. So Dr. Bartholomew talked about the different parts of the urgent care system. It's not just about one physical building, it's about pharmacies, it's about 111, it's about out-of-hours GP appointments. We believe that's an urgent care system which is pretty unrecognisable compared to, say, 5 or 10 years ago. And we think that's making a real difference to the ability for people to look after themselves and their families. But again, we want to check and make sure that we're hearing of any issues or opportunities or things that we need to think about differently. So we're live now, as I say, on a period of listening. This is not a consultation, this is a listening exercise. We want to hear from people, we want to gather their input, we want to understand what the issues or opportunities might be. That started last week, runs through to the middle of October, and will take several different forms. So a range of different targeted engagement activities with community groups. So my team and others will be going out to people on their own sort of turf, talking to them to understand their thoughts. So meeting with the Rotary Club of Newark, going to a Men in Sheds group, members of the Polish community of their own volition translated our materials and are talking amongst their community leaders as well. We've been briefing elected members, such as yourselves, and talking to other kind of interested parties. We've been making sure that we're talking to the media so that this message is getting out quite far and wide. We didn't quite achieve front page of the Newark Advertiser, but page 3 is good. So we're really keen that we get quite a volume of responses from people. And there'll be 3 face-to-face and 2 virtual meetings for people to come along to. So we're in variously the Holy Trinity Church Centre, Farndon Village Hall, North Muscombe Community Centre, and as I say, 2 virtual meetings as well. And all of those sort of point towards a survey which people can fill in either online or over the phone or on paper to gather their feedback. So the discussion that would be really helpful, Chair, by your lead to kind of have today is to get some feedback on those particular topics. What is the strength of feeling around those current opening hours, that 13 hours, 9 till 10? How else are councillor colleagues experiencing that out of hours urgent care service? What works, what doesn't work? What are you hearing from your residents? And where could we look to deliver improvements? And then also a bit of an ask from me, if that's okay. I'd be really keen to understand how you might be able to work with us or help us to really disseminate this material, share that out there, and gather feedback from your constituents. Happy to pick up any conversations afterwards if that might be helpful on that. But if there's any ideas right now, then that would be great to hear as well. So that, I think, is it. Unless, Lucy, you want to say any final words?
No.
Back to you, Chair. Thank you.
Thank you. Thank you very much to all of you for that presentation. I'm sure we have questions, so I'll open it up to the members of this committee. Councillor Wilmot.
Thank you very much, Chair. First of all, can I just say I have no problems at all with the ICB individual representatives or other people here today to answer questions. You are very competent in your work. I'm absolutely sure of that. I'm just questioning this report. I want to make that absolutely sure. Now, Newark is set to grow by around 9,000 houses due to the council's local house building plans over the next few years. Residents are concerned that a town of this size has no access to a 24-hour A&E, and now it's clear that you have no plans at all to reopen the urgent treatment centre 24 hours a day. I've had a look at the online consultation. I'm very concerned about this online consultation. It seems to have loaded questions. And the loaded question, it doesn't give residents the option to tell you what they really want, that they really want a full-time urgent treatment centre, nor a full-time A&E. They are not the question. The question is things about the present service.
Councillor Wilmot, if I can just intervene.
Yeah.
The residents will have time and the opportunity to speak to the members of the ICB. They can go to the public consultations. And I, as representing Newark and 23 surrounding villages, have emailed all of them and told them when the presentations are, and I am encouraging them to go, and when they've been, to answer the survey. So I don't think it's a case that you're not having the opportunity, but go ahead.
I'm saying that because it's not in the report. It should really be in that report.
But these visitors have said so.
Yeah. Well, just let me continue, Chair. Thank you, if you don't mind. Can I say the fact is that you are actually representing you will be presenting a reduced service as a positive solution. Says everything you need to know about the state of our health services, I'm afraid, at this county. It seems we have an NHS and healthcare system that's not working absolutely essentially. The PFI debt continues to rise at Sherwood Forest and the NHS Foundation Trust. The QMC and the City Hospitals rebuilds will be delayed beyond 2030. And obviously our Cavill Super Health Centre at Hucknall has been delayed by the NHS indefinitely. Some residents are waiting for long periods for a GP appointment, even longer for an NHS dentist. We have an independent review of maternity services at the NUH, and now Nottinghamshire Police have announced they are launching a criminal investigation into the maternity failings. I just wondered when it was going to.
What this
I'm
got to do
just
with the
about to bring
item.
him to order. We're discussing Newark Hospital, Councillor Wilmot. We
Yeah.
are not discussing Nottingham University Hospitals. That is for next month.
I'm
So
just saying that.
can we separate, please?
Yeah,
We're
okay.
not talking about maternity.
I'm just saying that the main hospitals in Nottinghamshire are overworked to the very limit and under extreme pressure. Yet you are saying that we are continuing to pile more pressure on them. I'm also saying that you say in the report that the GP appointments have increased by 7%. That is telling you that more people will need urgent care, an essential part of a hospital service. You say that the number of pharmacists has increased in Newark, but they cannot deal with urgent care. You say that NHS 111 calls have increased significantly. Yes, they can give you good advice, but you have to have urgent treatment at a hospital near to you. It is an absolute essential necessity. The quicker you get there, the more chance your treatment will be successful. You say you're committed to maintaining a safe, sustainable, urgent treatment centre. Yet some of the time patients will not be able to obtain treatment. People need to be close to hospital services. Chairman, as I say, there's lots of things in this report that I'm really concerned about, and I just hope that they take some effort into making sure that people do get the opportunity to say whether they like the service or they would like a full-time service. Thank you.
Thank you, Councillor Wilmot. I'm sure that people will answer the survey. It is one survey. I'm sure that the Sherwood Forest hospitals will have a lot of replies. Can I remind you that you have a member who represents Newark within your group, and when she came to the member briefing, she was supportive, not fully supportive perhaps, but she was supportive, and no comments were made. So she is speaking for Newark as well as myself. We've had the visitors explain to us, but I'm going to hand over to Lucy so that she can answer some of those questions, which I have to say have already been answered.
Thank you, Chair, and thank you, Councillor Wilmot, for your observations. I'm probably going to answer just one aspect, and around, you are absolutely correct in saying that as an integrated care board, we have got a duty to plan and allocate services according to the needs of our population, and you can be assured that we work very closely with colleagues in local government where we know that there are going to be population growth areas, and we don't just look at the net growth, we look at the impact, the age profile of that growth and the impact that might have on our health services, and that is part of our job, and we do that. So I'm going to hand this is two parts, I think, to my response to that. I can say categorically that in line with national policy, and we are required as part of the National Health Service to work within the line of national health policy, that the expected population growth in Newark doesn't impact on our provision of emergency care services. So A&E departments, we have two A&E departments, and the changes in population health need at population size at Newark will not fundamentally change that pattern of provision of emergency care. Dr. Briggs might be able to give you that kind of macro view on how we plan for emergency care. Just to remind you, what we're talking about today is urgent care, and urgent care is not care that necessarily needs immediate treatment in a hospital. And I think what I'd like Dr. Owens to do is to talk about actually how well the Newark Urgent Treatment Centre does perform for the kind of care that is properly directed to it. So I think if it's okay, if Dave, if you could talk about how we plan for services, and Ben, if you could talk about how the UTC is serving the population now.
Yeah, so over many years, there's been a number of reviews looking at the sorts of services you need surrounding an accident and emergency department to get the best possible outcomes. So if you've had a heart attack, a stroke, a fractured hip, what do you need around you to make sure you've got the best chance of living an independent life and living at home with your loved ones with minimal impact? And there's a number of things you need for that to be really effective and safe. You need access to intensive care, high dependency care, coronary care, stroke units, general surgeons, orthopedic surgeons, gynecological surgeons, obstetric advice. There's a whole group of essential things: MRI scanners, CT scanners, gastroscopies, cameras going down looking for things. It's a whole variety of things you need. And on the whole, in the UK, a population coverage of 300,000 would be the smallest population you would plan an emergency department footprint on, because that's the level of service you need to keep the skills, not just the skills of those people. So, although the population of Newark is growing, our current projections are that it won't get near the threshold to create a third accident emergency unit in Nottinghamshire. But that doesn't mean there's not pressures on our current accident emergencies, which I'm sure you're well aware of, which is why it's important that we consider urgent and emergency care and UTC in the round. And in particular, access to things like dentistry, general practice are very high up on our agenda. And we talked a little bit about, we have seen an increase in the number of general practice appointments. However, that doesn't mean to say we don't want to go further and faster and improve access. And indeed, recently, we've asked all general practice in Nottingham to look at their access and describe how they can make it better and improve it for the people they serve. And those plans are currently being enacted now. So we hope to come back with an improved position on that. It's a piece of work we still have to do and still doing, but we recognise that general practice is an important issue. That doesn't mean that those services can be replicated in an urgent treatment centre, and Ben will talk a bit more about what they do really well, because that's very much around minor illnesses, minor injuries, an important way, an important service to the people of Newark, but can't replace other services. And if there's issues with other services, we need to address those rather than layer services on which offer you suboptimal care, because we need to get the care absolutely spot on. And when we look at population health management, or fancy way of saying what we can do to improve our offer, the biggest thing we can do in the short term is improve our long-term condition management, the management of heart disease, the management of strokes, the management of respiratory disease. And those are elements of our community service and general practice working hand in glove. And we've asked for all of our neighbourhoods to look at how they can improve that care for the residents, including the residents of Newark, to improve that outcomes for those patients. That doesn't diminish the importance of the urgent treatment centre. It's an amazingly important resource, but it doesn't deal with those sorts of issues, and we need to get that right. So if I hand over to Ben.
Thank you. Thank you. Just to agree with Dr. Briggs, a lot of emergency care services and all the evidence we have is actually that when you centralise those things, such as maybe trauma, stroke, heart attacks, hip surgery, all the things, you get better outcomes for patients. Now that may mean distance is involved, but all the networks we have are putting, if you're very poorly, going to somewhere that has the expertise to deal with you is much better for you, even if it means a bit of additional travel. However worrying that may seem to people having to travel, we know the outcomes for patients are significantly better if you do that. And so it's really important to separate the emergency side of things from the urgent side of things. In terms of the population growth, actually, the if it's urgent care we're talking about, it's about providing really good urgent care at the times when it should be provided, and using all the staff we've got to the best effect that we can. And in terms of what the urgent treatment centre has done, we have the nursing staff that worked overnight. It's not a nursing staffing issue, it's been a medical staffing issue overnight, have moved to the daytime. That's led to improved response times, improved waiting times. It's one of the best performing 4-hour urgent treatment centres in the country. Patient satisfaction is very high. But the sort of local surveys and the CQC for the hospital, the trust, has put us in the top 8% of urgent emergency care patient satisfaction responses. And actually, the time taken to be seen has reduced. The number of people we've seen, so prior to the pandemic, we've seen 23,000. Last year it was 30,000. All those people are being seen in the hours that it is open now, which is the 13 hours a day, but the waiting times are shorter. So we're trying everything we can to improve the services. Like I said, and on the elective side of things, we've had a 5.6 million investment in that to improve the services. 2,600 procedures. We've got better waiting times, and hopefully we have got good patient response and patient feedback around the services we do provide for urgent care. If the population does increase, the urgent care provision should respond to that. But that's about the provision that it's open for, not the hours that it's open. They are separate issues, if that makes sense.
That's one more question, Chair. Thank you. If there was failure to deal with urgent care, can that lead to emergency care needed?
If they come back, so urgent care is things that are not serious or life threatening or risk of making you seriously deteriorate. The region urgent care centres, the national specification for that is to run 12 hours a day, is because those conditions that should be seen in an urgent treatment centre are conditions that is very safe to wait 12, 24 hours for in that scenario. Emergency care, when someone gets very sick for a variety of reasons, is not really linked to urgent care in that sense. So I understand what people would worry about. Well, if I don't get seen for 12, will I get worse overnight? I understand that concern, and actually the evidence says that's not the case. And there's always 111 to access for advice. If you're not sure, you can phone 111, which is either which can be directed out of our GP service as well. They can make that decision. Perhaps you should attend somewhere if we're not sure. But the answer is there is no evidence that if you use the right channel like 111, that urgent care provision 12 hours a day, they don't makes any difference to emergency care outcomes. I understand why the question's asked, but I can reassure you that's not the case.
Thank you.
Firstly, thank you for our visit to Newark Hospital a couple of weeks ago. It was absolutely fascinating. I'd recommend anyone going and looking at the theatre, because it's a modular theatre and it's absolutely brilliant. Going back onto this, opening times, it's 9 till 10. What time can people arrive, and what time is the last time people can be seen? Is it only open till 10 o'clock and then they have to move to somewhere else in the hospital? I just wanted to understand how that works. And secondly, Dr. Bartholomew, you said that if you ring 111 as part of the service, that people can get GP appointments. So does that mean GP appointments are being kept open for 111 calls? And if so, how many, and how does that affect everyday people getting appointments?
Just to answer the first question about opening hours. So the doors open at 9 o'clock. That's when the clinician staff are there. The last patient would be admitted at 9:30 to allow the staff to finish their workload by 10 o'clock. And so the times you can access the care are between 9 a.m. and 9:30 p.m.
Thank you. With regards to access to 111, so in terms of the absolute number and how the numbers are calculated, during COVID times, it was actually one appointment for 500 patients in a list size. So my practice, for example, 12,500 patients. I'm not that good at maths, but it's about 25 appointments during the daytime. Now it's 1 in 3,000 patients. So it doesn't seem too much, but actually that suffices the amount because it is spread across all the GP practices across Newark. So if a practice, let's say one particular practice has got 20,000 patients, it's about 7 or 8 appointments which are directly bookable per day from 111 to be done, and that's spread throughout the day, and that's done. So 111 call handlers will do a clinical triage, the clinical assessment through the triage, and if they think that individual needs a GP appointment, will directly book in with the GP call list, and then an appointment is given. Hope that answers the question. Thank you.
Hi, I've got a number of questions, and I'll be as quick as possible. With regards to the opening times, with regards to urgent treatment centres, how much of this is being driven by NHS England as well about a change? And the reason I ask this is in 2019, to be really specific, in March 2019, NHS England released a plan, and they released a press release. And just to quote it, local pilots will test how the new NHS standards, blah, 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 with hospitals to be measured on their success in reducing overnight admissions with regards to urgent treatment. So the NHS England had within its plan in 2019 to reduce hours in urgent treatment centres. So I'm just wondering, has any drive come from that at all, or is that nothing to do with it whatsoever? Because obviously that's a national initiative. Urgent treatment centres, when and you will all know this, when it was first talked about, intervention and prevention was often talked about, and I know Dr. Ben Owens has talked a bit about that already, about the intervention and prevention and the very different. I have a bit of a different experience with regards to that when I've been in urgent treatment centres. I've seen a lot of people with life-limiting illnesses that have gone to an urgent treatment centre. It's better for them than the A&E. They've got what they've needed there and then when they can't get in to see their GP for whatever reason, and they've gone away and they haven't ended up in hospital. And we're talking about lung conditions that are on the rise nationally, and particularly in Nottinghamshire and in the area that you're talking about, heart conditions, etc., etc. So the intervention and prevention element with regards to urgent treatment centre, for me, is a critical part that they play. So would like some further information and even data with regards to that. Intervention and prevention, of course, would be very difficult for you to measure, wouldn't it? Because who knows if that person that's gone to A&E, if they'd gone into the urgent treatment centre, wouldn't have ended up in A&E, if that makes sense. So very, very difficult to measure and very, very difficult to gauge. My other two comments are with regards to 111. Regards to GP services, and I just want to put this out there. I'm not at any point criticising GPs. I think they do an absolutely excellent job under the current circumstances, as does everybody in the health service. 111 doesn't work for a lot of the time. It really, really doesn't. I have endless conversations of parents with children where they're supposed to be a priority, that are supposed to get a call back and don't get a call back within the time frame, or actually haven't got a call back to the morning. People with life-limiting illnesses, I say lung conditions, and I should say that my father's got one. I'm involved in a support group across Nottinghamshire with regards to it, that will ring 111 because, one, they don't want to go into A&E to avoid infection, etc., etc., and if they get the care somewhere else. So 111 isn't necessarily working. I don't agree that it's working. I really, 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 really don't agree that it's working as it should be working. So when you combine that with your ongoing plans with regards to the urgent treatment centre, when you combine that with the fact that people can't get the GP appointments when they need to, a lot of people can't get the GP appointments when it's this catalogue of people perhaps not getting the care exactly when they need it. I don't believe that the health service is flowing as efficiently as what is being suggested here today. I don't think that is happening at all. I think there's a lot of vulnerable people with health conditions and children, etc., that are thinking. If you talk to parents, not all parents, no, Mike Adams might disagree with me, but if you talk to parents and you talk to people that are carers with people with an illness or have a degree of vulnerability, when is the bit that they fear the most of when they're going to get ill? It's at night. If my child gets ill at night, I worry because I know I can't speak to a GP, 111 can take forever to get through. When I speak to somebody, I get a call back, and I've not always got a call back. I didn't get a call back when you had a temperature of 41 degrees in the night until the morning. So the biggest fear is at night. It really, really is. And this is why I'm talking about prevention and intervention, because what I ended up doing is getting the car and taking my child to A&E, because I didn't know what else to do, because his temperature was just going up and up and up, and I didn't want it to get any worse. So my question overall with regards to this, how much is this in an ideal world? If you could get the standard, if you could get the staff in and everything was there, would you keep it? In reality, would you keep this open? Because we're all realists here. We understand the pressures under the NHS. We understand that there's huge staffing issues. This is a national thing as well. But in an ideal world, an urgent treatment centre in my world would be open during the night as well. That's what I think. Yeah, in an ideal world, that would happen. And in an ideal world, 111 would have be more efficient. And in an ideal world, we'd have more GPs that are under less amount of stress as well for what they're going through. That may be an ideal world at the moment. But is it something long term that we should be striving for, and that treatment centres should be open overnight as well? And that's it. Thank you.
Yeah.
Can I just ask a question first? Related to what Councillor Welsh has just said. I could have dreamt it, but I think I asked, it may have been Alex, if it was, we discussed the fact of how there used to be a GP sitting at Newark Hospital, and if you went down at night, if you rang your GP at night, you could be sent down to see this GP who was sitting outside a little ward area. Now that has gone, but I think when I mentioned this, possibly not to Alex, so I won't blame you, Alex, until I know whether I've dreamt it or not. I thought somebody said you can ring your GP now in the night and you will be directed what to do. Is that true?
So, yeah, sorry, I think you did. I do recall you mentioning it, Chair, actually. And what I was going to say, if I can respond to Councillor Welsh, and I will cover that, because of course we do have an out-of-hours GP service, which doesn't operate from Newark Hospital anymore, but is available. So GPs, you know, if you, your child, or your relative meet the right criteria, a GP can be dispatched to see you at home. And I think there would be a suggestion, and I would defer to my clinical colleagues here, but if there is a question about, I mean, generally, the decisions that get made about children, they take very low risk. And actually, a lot of people say, my child's been directed to hospital, I wanted to keep them at home. But there is the capacity, particularly if you go through 111, and out of that, your need is clinically assessed, for a GP to come to see you at home, to see your child at home. And then they may make the decision that your child is able to be cared for at home. They may suggest a GP appointment in the morning, or indeed they may send them into hospital. So I think what we want, I was going to say, to add to the pattern of care that we've described, there is a GP out of hours service for people, which I think is probably better than people coming away from their own homes at night to attend for that kind of thing at somewhere like Newark. To answer your question directly, Councillor Wash, I think, and I should check this, but I think the UTC guidance was originally issued by NHS England in 2016. And it was the beginning of sort of saying, we know that accident emergency departments are overburdened, and they need to be there with, as Dr. Briggs described, the right, not just people, the infrastructure, the diagnostics, all those sorts of things. They need to be there to treat the people that need that kind of care as quickly as possible. If you need urgent care, the quicker you get that care in the right facility with all the scanning and all that, the better your outcomes. And it was beginning to be recognised that we created quite a complex, inadvertently, system of care in the NHS. So the long-term plan said, at the core of it, for those people that are really seriously unwell, we've got an ambulance service and we've got an A&E departments planned according to population health need. And it was about then simplifying what wraps around that. And it is, as we've described, urgent treatment centres, which do run to a national specification, pharmacies, 111, out of hours general practice. And what the national guidance does is to say they are your choices. Do choose properly. Do rely on people like myself and my colleagues here to make sure those things all talk to one another. But it is a national policy to simplify access to urgent emergency care. If it's in emergency, dial 999 and attend an A&E. If it's urgent care, you have those other ways of accessing care. So I don't think that. So I think our job is to make it work, and part of what we want to do is to talk to the public, to hear what people have got to say about 111. We have started to hear over the last 2 or 3 years that 111 is providing people a level of comfort that they will get the right assessment and the right signposting, but there's always more to do. So I think in direct answer to your question, I think what we're really keen to do is to make the network that we've got work best for our citizens, make our A&E departments flow for people that need them, and make other urgent care work around them. And in that context, the national specification for urgent treatment centres does work, and I don't think it's a resources-driven policy. And that would be, sorry if I hand over to Dr. Briggs.
Yeah, so the guidance you talked about in 2019 around the overnight admissions was really about senior decision making in the ED department. So what NHS England wanted to avoid was admission being a less than active process. So what NHS England wanted to do is ensure that senior decision makers were involved in the decision to admit, because being admitted to hospital can come at some consequence. You can lose a lot of mobility, you can lose a lot of independence, and if that care can be delivered at home, then it should. I mean, you mentioned, Councillor Welsh, around the importance of some of the long-term conditions and about getting that right. We're not sat here saying we have got that right. We have got more work to do on that. And we have just had, a few weeks ago, a summit around breathing conditions, around some of the actions we know we need to do to improve that picture. So we know we need to do more diagnostics. We need more people who are out there now without a diagnosis of a breathing condition that should have one, particularly in some of our more vulnerable communities. So we've got to do some work on that. We know that not everyone is on optimal inhalers or medications, so we have to do something about that. We don't always get people with the right vaccinations, so we know we need to do more work on that. And when people become more unwell, we know the pathways don't always work for them. So we've got a task force looking at how, when you have those conditions, how we more effectively as a system deal with them. So we are not sat here saying for those complex long-term conditions it's perfect. We are aware, and the systems are aware, colleagues in acute and primary care are aware we need to do more together to give better outcomes and better treatments and better care for those individuals. You've got something in my commitment that we're going to keep on at that until we've got a much better position. I think that's a different question to say, what should the open hours of the urgent treatment centre be? Because they aren't designed to deal with those conditions. They are designed to deal with important but less complex conditions, and we have to, in my view, get both of those things right and have to improve the offer for those who have got chronic long-term conditions, and the need for that to be addressed in the evening is critically important, and we need to do more around that. There have been improvements, and as I said, the urgent community response has been a significant improvement to the people of Nottingham, Nottinghamshire. It is one of the people all the country come to look at to say, how can you do it well? But we'd still have to do more.
If I could. Thank you. Yeah, just to answer some of your concerns. So I understand, I'm a parent, I understand concerns about kids overnight and temperatures, and I understand that completely. And just in response to, and just to back up what Dr. Briggs has said, yeah, the national 2019 thing was about reducing people who require urgent hospital treatment, which is different to what an urgent treatment centre is designed to do, which is treat people who don't require inpatient or day attend hospital treatment. That's people who need intravenous antibiotics, people who might need a blood transfusion, people who might need further scans and tests, but don't need them up for the morning because it's not that urgent. And there's a risk to doing some of those treatments overnight as well. So that's what that drives. It was reducing urgent hospital treatment patients, not urgent care, which is what we define as conditions you normally see your GP with, or minor illness, minor injury, that sort of thing. So the terminology is not particularly helpful, but they're both called urgent, but they are different things. So just regarding heart conditions, I can't think of a single heart condition that attending an urgent treatment centre would stop you then needing hospital treatment. Some chest infections and things, and that's why people with long-term conditions like asthma and COPD have things like rescue medications. So if you're at risk of recurrent infections, we try and get people to have their steroids or antibiotics in the house as a package. So if they do deteriorate, actually they can do that. But these things are not so emergency and urgent that actually overnight, if having some tablets of antibiotics between 8 at night and 8 in the morning would be the difference between admitted to hospital or not, that's not the case. If you were deteriorating to the point where you would need admission, having antibiotics 12 hours early would not change that outcome that you would need hospital treatment and admission. I understand that concern, why the question is asked, but to sort of reassure you that that's not the same thing. And actually, it's never a bad thing to have your antibiotics. I feel better I've got them, but actually, if you needed them that quickly, it would make that difference. If you need hospital admission the next morning, a tablet of antibiotic is not good. It takes 12 hours to get into your system properly, so it would not have made that. And so again, I can see why people would want to know that and feel reassured by that. But the evidence we have is that is not the case. But I totally understand why that anxiety exists.
Chair, can I just pick up one point on 111? Is that okay? So that's one of the things we're keen to hear, Councillor Welsh. So thank you for sharing your experience. I just kind of wanted to share, there was a piece of work that Health Watch England did a year or so ago, quite on a national basis, and the results from that showed that 3/4 of people were satisfied with their experience of 111. And my personal experience is I've had really very prompt callbacks. So I guess I'm signalling that we do have evidence that suggests it's a service that is well used, certainly well used, and also does deliver what we need it to. But that's not a universal experience, absolutely acknowledged. And that's, again, why we're out talking to the public and want to hear people's responses on that. And Dr. Bartholomew, you and I were talking the other day about sort of your experience of 111, almost as either a customer or a supplier to it as a GP. I don't know if you want to say a few words on that.
Thanks, Alex, and thank you very much, Councillor Welsh. In terms of just going back to the thing of 111, so it's interesting understanding where you're coming from. And yesterday I was on call, so I do work in the call front. So and yes, when it works, it works. And like Dr. Briggs said, we are not here saying that everything's perfect, and there are improvements, but it's a lot. The significant improvements we have seen over the years, and access to urgent care is just not UTC. It's one component which complements access to urgent care service provision. So 111 is a key component, same as GP access, same as out of hours access. And I used to do out of hours access, provide access as a GP as well, and through pharmacies as well. So there is that development service. So going back to the question about it, there is the thing about having access working with the public. Going back to Alex's, when we went to the last slide about how do we work with yourselves in terms of engaging with the public about accessing the right service at the right time and having that differentiation. It is an ongoing process, but the confidence in 111, and we have seen, and I see through discharge summaries or calls coming through 111, there is significant improvement where patients have direct access to a GP after going through 111. And sometimes it may not be a GP appointment. They do flag us and say this patient needs an extra prescription. For example, they've done the clinical advice, but the call which comes through to us is to supplement that consultation with further advice or a callback or a visit or a referral to a community service. So it's again a holistic service which is provided, and it has been evolving and improving over time. So I see it as a clinician, but likewise would very much like the feedback to improve the service. Thank you.
Yes, Councillor.
In order to get an out of hours, to speak to an out of hours GP, which you talked about as another alternative, what number in Newark do you phone to get that? So where I am, I have to phone 111 to get an out of hours GP. Is that the same here? Because what I am talking about is the time from when you phone and when you speak to a GP that tells me to ring 111.
So yes,
no, mine isn't. Mine's not them. No.
So sorry, Mark. So for the avoidance of doubt, so Historically, it used to be you ring your GP surgeries and the call gets directed to the out-of-hours service and NEMS. So in the same way, now it does also say ring 111 because it's for, I suppose, again, it's for patient experience and access is to ensure that we don't have, there are 38 odd GP practices in Mid Nottinghamshire. So rather than trying to do, it's to try to get a service which is uniform in its access and for public, for easy to remember through 111 for non-life threatening and obviously 999 for life threatening and emergencies.
Yeah, and if you are clinically assessed as needing a GP to visit you, then that will make that happen.
So my last point is I would like to see what the timeframes are on that, because that is the bit that concerns me. It's from the point where you phone 111, tell them what the situation is, then the gap between someone phones you back, which on the occasions that me and my family have phoned, it's been someone that said it hasn't been a doctor, it's been a nurse, which is fine, it's a nurse, and then it gets a GP. So sometimes it's not until the morning where you actually get anything back as to what kind of treatment you actually need. It's that time frame, I think, with regards to 111. When 111 answer, they're fabulous, absolutely brilliant every single time. It's that time frame that still concerns me when I'm talking about being overnight, where people feel particularly vulnerable.
So if we hold that data, which I imagine we do, we'll provide that.
Thank you. Councillor Bailey.
Thank you very much. I just want to thank you guys for coming back so quickly on this issue. I know we had a bit of a moan about these endless extensions. I just didn't realise it'll be on our next item. So thank you very much, and thank you as well for providing the surveys you're going to be handing out, because this is a item that has many moving parts. You have had investment in Newark. I think it's over £5 million investment. So you've got expanding the services there, but you've also got a situation where staffing is an issue across the NHS. So we need to make sure that we remain sustainably staffed. And so, I mean, we've always talked about this perfect world where, if it's perfect, you have all the staff, you'd open it 24 hours. That's not a perfect world. So we need to make sure we're using our staff effectively. And as I believe Ben has mentioned, making sure that staff are working appropriate hours and in a way that's sustainable with the equipment available. I think this is almost one of the ways that you've approached very much a difficult situation. So I suppose at this stage, it's making sure that people have their input, making sure that people have their say, and be able to, for yourselves, to answer the questions I think many people have. So I think Councillor Eddie's mentioned one. When can you actually go into the urgent treatment centre and actually see? I believe Councillor Saddington has also mentioned about the GP aspect inside the treatment centre. And I mean, for myself, I suppose some of my questions have been answered, but when are we expecting almost a final report back on this? I mean, I know you mentioned the consultation goes till October, and I believe you'll be coming back to the future meeting. Are we expecting this to be finalised by the summer, essentially? Or are we going to be having another extension?
We're here, Councillor Bailey. We heard what you said.
Thank you very much.
So thank you, Councillor Bailey, for kind of recognising that. I think we committed, or Lucy committed, that we would definitely be back for Christmas, but the Christmas elves worked overtime over summer to get us here, and I think that's designed to signal that, we're keen to get to a position of certainty on this as quickly as possible, but we need to make sure we gather in all the right evidence and do that right. So we're not rushing to something, but it is not our intent at all to be coming back to you next summer and asking for another extension. So this runs through to the end of October, this particular listening exercise. We're also doing a number of other things kind of in and around this period, including working with a body known as the Clinical Senate, which is a regional group of expert clinicians and other kind of managers and experts who are going to really help us check, have we asked and answered all the right questions here? Have we missed anything? What other best practice from other parts of the country can we draw on? So we'll take that along with all the other evidence that we can draw in, and that's probably when I kind of hand over to Lucy to say then what happens next.
Yes, I think just Councillor Bailey, I would reiterate, and I think Dr. Owens would reiterate that regardless of resources, we are committed to making sure that people that need emergency care get the right care in the right place with the right infrastructure, whatever. Similarly, we're committed to ensuring that people that need access to urgent care get it in the right way at the right time. And I don't think the fact that I think the discussion about the overnight opening hours of the UTC is different to that. I think people do need access to urgent care out of hours. We didn't feel before the pandemic, and there is nothing that tells us now that is best provided from a physical urgent treatment centre. But we do. I think the really important thing is to keep listening to what's working. And make all the bits work together. So, in short answer, so we have to take the insights of our population, and that is part of our job. We and we want to hear what you've got to say. So we'll have gathered all that information by the autumn. As Alex said, we've got the Regional Clinical Senate coming and looking at our model, and they will just look at it from a clinical perspective. They're not interested in things like resources. They will look at what is the profile of our population. They'll look at the things that sort of Councillor Welsh has helpfully added. What do we know about our population, about future health needs? What is the demography? What sort of illnesses, what sort of long-term conditions do our population have? And then they will advise us about whether our pattern of urgent care for Newark and the surrounding areas is the right one. I would suggest that when we bring those two things together, we will probably be coming back to you early in the new year. I think I don't want to commit myself just now, but because we don't know what the outcome's going to be. But I would say, taking the patient insights and the clinical view, we should be able to come back to you in the new year with a recommendation.
Adams.
Thank you very much. I just wanted to start off by talking about parking, which will not be a shock to any of you. I was going to start talking about whether it's to do with the quality of the tarmac or something, but I thought I'll leave that alone. So I just wondered, on the 80 extra spaces that you're currently working on, how long before that is in place? Which again, like I said, will come as absolutely no shock to you whatsoever. The second thing really was to talk about the 111 connections GP service. Now I know the Deputy Chair raised the point, a part of the point I was going to say, and I know we discussed when we were last here, I think it was with yourself, Dr. Bartholomew, around the actual connection of using a wider call queue to manage NHS incoming calls, so that therefore, if there was a receptionist off, it wouldn't affect the somebody getting a local GP appointment. And this feels like a really clever precursor to that, because you get that initial fault finding, if you like, in whatever the medical version of fault finding is, you effectively get to do that initial triage. Is that what they call it? That's what they call it. I've not been wasted on this committee, Chair. I thought that was really clever, and I think again that sort of I'm starting to see how it's all coming together. And I think, referring to my own local GP who uses they use social media to communicate if they've got staff issues. They use their website to do the same. They take online appointments now as well. The NHS app can do repeat prescriptions. So I've definitely seen a marked improvement in the overall offering. I mean, I remember being a kid and I remember seeing a sign on the wall: if you've been waiting for 40 minutes, please come to the reception and remind us that you're still waiting. Now, I've not waited for 40 minutes in a GP reception for as long as my children have been alive. And so that experience, I think, I can remember that as a marked improvement across the whole service. Just referring to a recent experience with regards to how we were dealt with, there was a couple of weeks, there were some real biting creatures flying around, and one of my kids had been bitten in 2 locations, and they'd swelled up to the size of golf balls, and so it was one of those where we were a bit unsure about it. Rang up, they said it was dealt with initially, like in some call handling, then it was referred to for a callback, which I know Councillor Welsh mentioned about callback times. We were called back the same day, and we actually saw the doctor same day as well. And we were then prescribed an antibiotic which resolved it, and it's now completely gone. So I wanted to highlight that in a very recent experience, we've had a very positive experience with my children, which I thank the service for. And I know that's not in every case, and I recognise that in our own area, and there are challenges, and specifically when we have staff shortages. So just a slight staff shortage question: if there are problems with people being off sick and that sort of thing, how does that work with dropping in staff to cover that? Or is it just like the GP just has to manage that throughout the day and that is it? There's nothing they can do. They can't pull in any extra staff from anywhere. So that was, really just about that, how you manage that if that happens, and also obviously about the time for the car parking to be active. Thank you.
I'll take everything but car parking. So thank you very much, Councillor Adam. So in terms of starting from, and in no particular order, so in terms of workforce in primary care, yes, so I mentioned previously in Mid-Nottinghamshire, 38 practices. And yes, staff are the crucial component of running the service efficiently. What's happened over the past, going back to what I said about workforce over the past 4 to 5 years, is practices now work collaboratively across a network or a primary care network. So particularly during COVID times, it's effective that from clinical to non-clinical administrative staff, practices do support each other. So even if a GP, let's say, the practice down the road, if a GP for whatever reason is not able to come in because they're poorly or for their needs, we would support each other, and patients do have the flexibility to book appointments. I wouldn't say it happens all the time, but that's at the time of crisis to ensure there's a continuity of service. Now, and that is same for with regards to secretarial service, administrative receptionist staff. So in Mid-Nottinghamshire, there are 6 primary care networks, and Newark itself is one primary care network. So the practices within Newark collaborate and work together as a primary care network. So that gives you a bit of a picture about how the primary care is set up and how they work in partnership, more or so. But each practice is still an individual practice, and it's more, one for a better word, an individual business unit in terms of service provision. Coming back to things about clinical triage, I agree. So I've said before in this committee, when a receptionist asks, how can I help you? Have you got a temperature? It's not because the receptionist is being nosy, it's part of the triage. It helps the clinician to make a decision. I said yesterday I was on call, so when an appointment request pops up in the screen with 2 or 3 basic lines, it helps me to prioritize that call and sometimes either call that patient immediately or actually book a patient with the relevant clinician straight away, and that's been done. And what's happened over the past, again, few years is the advent of using software, SMS, where feasible, the majority of the patients do, and I do acknowledge the fact not all patients do. So for those patients, we will call and we'll do assessment where we could send test results, prescriptions, everything very quickly digitally as well. Again, that opens an avenue for access, which improves patient experience. Talking about telephony, one thing which we are really keen to promote, and it's part of an NHSC direction, is using of cloud telephony with the callback function. So what that does is you no longer, where we have cloud telephony, so for my practice as an example, patients need not be on that endless, your caller number 38 and be on that. So there is a callback function to do that. Again, that's part of an access. So you can see all what I'm saying is the things, the evolution of NHS in terms of trying to offer a better service. And in terms of the appointments itself, it's a variety of appointments. So it need not be with a GP, as I said before. It could be with a physiotherapist or an advanced nurse practitioner, or maybe even a social prescribing link worker who would be able to understand, have a discussion with yourselves or the family to understand what the support are. So overall, I hope that gives you a flavor of how general practice and primary care in a wider sense is working, and also the partner or the collaborative working with GP practices across any footprint. So thank you.
So I've not been ignoring you. I've just been sending a text to somebody because I don't know the answer to that question, but I will try and find out by the end of the meeting for you, if that's okay.
Absolutely. It was the first thing we saw. I can tell you they have a plot of land and they are going to build the car park there, and is it flat? It's not going to be multi-storey, is it? So when a man can go out and paint some yellow markings or white markings or whatever colour they have on the car parks, they should have a car park. And it was my understanding from Alex that the staff will park on that, which is slightly to the side of the hospital, behind a supermarket. I think it's a co-op. There's a piece of land, and they've been allowed to have some. And they're putting the staff to park there, so that at the front of the hospital, where the main car parks are, and it's an old building, so you tend to go in and you've got the main car park, and then you've got little bits where you can put a car or two cars, so you can snook in there and park as well, quite legally. So the patients will do that, and the staff will go to the new car park. So believe me, we've got car parking space at our hospital. I'm correct in that, aren't I, Alex?
Yes, that's arranging it better, and we'll get the date. I think it's day.
Yeah, so there's car parking. Right, Councillor Turner.
Thank you. Yeah. Just one thing, going back to 111, I experienced 111 in June 2021, and my treatment was 5-star. Just thought I'd add that to the debate. With regard the Newark Urgent Treatment Centre and opening hours, I think the communication is key. So I think, Alex, it's you've got a tough job over the next few months. The challenge, I believe, one of the two key phrases here: emergency treatment. General public, I would suggest, wouldn't sort of get quite easily to put the two together and not differentiate between the two. So the challenge to you, I believe, is getting that message across to general public that emergency care and emergency treatment aren't the same. Would I be right?
Yeah, I think so. And I think Ben has covered that. Care, emergency care, and they are very different, and they do need a very different response. And I think you're absolutely right. And I think it's what Councillor Welsh. We've got to make it all work. We've got to help our public to understand how to make it work for them. But that's a very fair point.
And just to add to that, that's why the national thing is to call it an urgent treatment centre and an emergency department, to try and really separate the two, to make it as clear. And obviously, there's always more we can do around that front, but it's in the name, and it's really trying to make people understand that.
Councillor Anderson, are you ready? Or do you
I am ready.
You're ready.
I would just like to ask, at what point in the treatment process at the urgent treatment centre would a patient be transferred to a hospital with perhaps emergency care facilities? And would transport for this person, would it be available to patients to get them there?
Thank you, and it's a good question. And so, obviously, people do walk in the door with things that are more serious than the urgent treatment centre can provide. The number of one of the things to reassure people a little bit, and we've had a lot of time monitoring what's happened in daytime hours and out of hours, and there's been no increase in the number of transfers out of Newark to Kings Mill Hospital or Queen's Medical Centre. And also overnight, there's been no increase in the number of ambulance journeys from the Newark area to Kings Mill Hospital. So there hasn't been any significant change in sort of large numbers of people being transferred by ambulance out of hours and also in hours. For the process, if you have something that needs further workup, sort of it's a hospital urgent thing. You might need complex scanning or a senior opinion. Some patients make their own way in their own transport. Those that require an ambulance will call the urgent treatment centre staff will call an ambulance. They call EMAS and they literally book a 999 ambulance, and they're categorised again on the level of severity of how poorly the person is. So you get the same response times in the treatment centre as you do if you were in the street and called 999. So people aren't disadvantaged if they do that. And the number of transfers is very low, and they're usually for things it might, so someone with a fractured ankle that actually needs to be operated on. As a good example of somebody who would need to be transferred out, so they may go in with a painful ankle they've fallen over on actually an operation. Sometimes people present who are stable with serious conditions, and then they're transferred out and assessed appropriately. Does that answer your question?
Yes, thank you.
Okay.
Who with that answer? Yeah, you don't want to come back. Okay, Councillor David Martin.
Yeah, thank you, Chair. I think it's always going to be a hard sell when 12 years ago they had full A&E, and it's gone downhill from there. And then of course during COVID you cut the urgency treatment centre down from 24-hour to 12-hour, which fulfills its statutory obligations. I understand that. And there's a lot of difference between emergency care and urgent treatment centres. I think the biggest problem for the residents of Newark, with an ageing population, is the geography of it. And you talked about the requirements for A&E, and I can see now why it went to Kingsmill, because the population centres there and the services are there. So that's why you've had that evolved pathway. It's around about 375,000 people attending, are living around Kingsmill. When you take Newark and Sherwood, Ashfield and Mansfield into consideration. But we've just had 17.5 million on a new accident and emergency village at Bassetlaw, and there's only 116,000 people in Bassetlaw. So why is Newark different? That would be one of my questions. Because the geography of Bassetlaw and the geography of Newark and Sherwood is much larger areas, and that's if you were to ask the people in the outlying villages around Newark and Sherwood, like Collingham and Misterton and all those, the problem is getting to it, and that's the problem. I mean, I live on the very edge of Ashfield, and it takes me 10 minutes to get to Kingsmill. It takes me 25, 30 to get to Newark, and that's the problem. When you've got an ageing population who have accidents, especially as Councillor Walsh says, during the night, so from 10 o'clock till 7 o'clock in the morning, that's the worst thing. And obviously we've got exponential growth all across the region, so round about between 8 and 10,000 per district over the next 15 years. And I think that's what we should be looking at. I don't want us to be missing the boat and asking people now what they think about is already here. We need to look beyond that. And I heard you say it earlier, Lucy, that you do strategically plan. And you really do need to strategically plan, because there are 10,000 houses developing in the plan around Newark alone. We've had 2,500 on Lyndhurst, which is a spit's throat in Kingsmill. And there are around about 9,000 being built in Mansfield. We've only put a plan in for 4,000, but that's not going to stand. There's going to be more, and we all know that's the way of the world. But my question is, are we future proofing? And of course, the whole NHS system relies heavily on triage. So when whether you ring up your doctor, your primary care, 111, A&E, doesn't matter, ambulance, it's all triaged. So I'm thinking that there could be some kind of triaged, smaller, hybrid type of A&E at Newark. That's where I think we could go, because you're putting that burden on, and I've had a lot of conversations with Councillor Darby about it. I went to see Paul Robinson, the Chief Exec of Kingsmill, and people say to me, why does what happened in Newark and Sherwood bother you? Because my residents go to Kingsmill, and so do they. And that's why it affects me more, equally so. But the biggest grief I would have if I lived in Collingham or Bridgewater or wherever it was, where Councillor Darby represents, it would be the travel element. That would be the travel. It would be the travel element, especially for people who are in panic mode, in dire need, in the middle of the night with kids, etc. Because we had exactly the same kind of issues with the A&E at Bassetlaw, which the Children's Assessment Unit. It was exactly the same type of problem. You change the name of it, and it fits different criteria. It doesn't have to meet those regulations then.
and that's a good way of changing the system and making it adapt and suiting it to what you want it to do, but it doesn't always meet the needs of the people. And I know what you're saying about people not coming to Newark in the middle of the night, but for the last 12 and 13 years, you've been sending them to Kings Mill, and that's why no statistics are going to show people coming to Newark at night because they've been directed to Kings Mill or Queens for A&E. So that's why the figures won't be there. So I would be interested to know when you come back next how many people from Newark and Sherwood, and how many visit Queens and how many visit Kings Mill. That's what I'd be interested to know, because that would give us the meat on the bones of whether there's actually a current requirement and if that has a potential for growth. Because I'm sure you've got that statistic, and that because it's the actual travel element that's the biggest problem for members of the public. That's what I get. So that there's my take on it. Thank you, Chair.
Yes, I think I can, and I think I probably would need support from my clinical colleagues. So we will have data about the number of Newark residents visit Queens and Kings Mill A&E. We've also done lots of work over the years looking at ambulance conveyances and what that impact that has on mortality rates for residents of Newark, urban and rural. And that is still telling us, Councillor Martin, that the safest place for you to go if you have a very serious emergency need is to an A&E department that does need a level of service provision and interdisciplinary support that means that you will have the best possible outcomes. I have to be honest, there isn't any. I think we would be, certainly somebody like the Clinical Senate would be very strongly advising us against developing hybrid models. They'd be saying, make sure your urgent care works, make sure your emergency care works, make sure they work together. And that is what I think we need to focus on. But you are absolutely right. We do, we have to look at our population growth. We have to look at the numbers of GPs. I think Dr. Briggs made a very good point in response to Councillor Welsh. If we could avoid a lot of urgent care by better investment in prevention, and that is out of hospital services, I think that would be a huge benefit to both our populations and the way we plan our health services. So, we do keep all of these issues under review, but our focus at the moment is on continuing to invest in urgent care according to the sort of national policy around how we should provide all of our urgent care services. We do continue to invest in our EDs, both at Kings Mill and at Nottingham, to make sure they've got the best diagnostic equipment. And we do look at, we need more equipment because more people are coming in. But I take your point. We do not rest on our laurels. That's not what this consultation is about. This consultation is about the opening hours of the urgent treatment centre at Newark. But we will very happily, come back to you at any point for wider scrutiny about how we're planning urgent and emergency care in its more broad context. So, feel free to call us to be scrutinised on those other matters.
Just to come back to your point as well, I understand why you're asking the question. So when the A&E at Newark was changed to a minor injury unit, now urgent treatment centre as the name changes, the reason it changed was it could no longer be called an emergency department A&E because the specification for an A&E is much clearer in intensive care. I think Dr. Briggs has said, so medical, surgical specialties, on-site, resident, able to operate blood transfusion, so huge numbers of staff and facilities available, and they were not available at Newark. So when it was changed from what was based as an A&E 12 years ago to an urgent minor injury unit and an urgent treatment centre, it was because it no longer fulfilled the specification for the emergency department is much clearer now and is much higher than it was in the past. So it wasn't that the services were downgraded, it's what actually there was just national standards and requirements for an emergency department significantly changed. And actually, we haven't seen large numbers of people from Newark area attending Kings Mill overnight. If you compare it to the Kings Mill the Mansfield population as an example, the ambulance transfers, which are more poorly or higher risk patients being transferred across, hasn't particularly gone up. Now can be pre or post pandemic. And what we have seen when it's been closed overnight is, after we've seen with lots of other units that have gone through a similar pattern in the country, is the people with urgent treatment needs that were attending overnight simply attend in the daytime hours. And as you said, we've seen about a 5,000 or about 20% increase over the last 5 years of the attendance to the urgent treatment centre, which is all occurring now in the daytime. And because you have an urgent treatment need, and obviously you can't access somewhere directly locally overnight, most people will wait till the morning and then attend in the morning. And so the urgent patients are coming in the daytime, and that service has been met and the wait time is shorter. But the emergency transfers out of the Newark area haven't changed. Population changes, there may be a change. I understand the anxiety people have about it's in the middle of the night, how far will I have to travel? If you need to travel, there's an ambulance service for that. If you're not so poorly, then actually the out-of-hours GP service can respond, or the urgent treatment centre or their own GPs are available in daytime and evening hours to try and meet that need. So again, totally understand why people want to know that as a question, but that's the patient need as such, how the patient need is met. And a hybrid model is a really risky business. You can't staff it to the level you would need, and that creates a danger, because we know that it's better to travel to a specialist centre than it is to go to a centre that's not geared up to deal with you, and also not used to seeing that kind of presentation. I hope that helps.
Perju Horan.
Thank you, Madam Chairman. I was on the phone to a friend of mine who lives within the Newark Hospital catchment area, and after we spoke about something completely different that he spoke to me about, I mistakenly mentioned to him that I was substituting on the Health Scrutiny Committee looking at Newark Hospital. So I got the rant then. And what he said was, can you make sure that you tell them that it's a lot easier to get a carton of milk or a loaf of bread in Newark than it is to have service at Newark Hospital. And I thought at the time, well, that's a typical pub sort of comment off the cuff to completely exaggerate the situation. So I never thought much more of it. And I saw in the report, in the second appendix, I think, first appendix, you've consulted with elected representatives, and I mentioned that too, and he said make sure you get it across that our MP should be getting more funds and more funding for our hospital. But anyway, enough of my friend. By the way, Madam Chairman, as I'm talking about, as I'm on the subject of the briefing to local elected representatives, including county councillors, Councillor Debbie Darby would like your comments to be completely scrubbed from the record. Your earlier comments that she didn't make any comment did not in itself indicate that she supports what is in this report. She just wishes to make that clear, and she will, I'm sure, have an opportunity to assert her actual reaction to the proposals later on. I've got to be honest, I feel sorry for members of the Integrated Care Board. I'm pretty much of the school of thinking that you are charged with making decisions that used to be taken by the political class, and over the years that has been shoved to one side, so now we don't really make decisions on health matters or indeed interest rates. And when the Prime Minister or the Chancellor argues that they're going to get inflation down, absolute nonsense. It's the Bank of England and the interest rate committee. So the decisions that used to be taken by the political class, we're now just shoving and having a go at people who are simply trying to do their best for everybody. But the reason why I'm here today is I'm substituting for Councillor Carr. But in actual fact, Councillor Debbie Darby is disappointed that she's not here to be able to substitute in Councillor Carr's stead, because guess where she is today? At Newark Hospital, member of the family, I think. And I've spoken with Councillor Darby at length, and obviously to get a broader picture. I'm based in Bingham, so it's not my default hospital if that's needed. And from her personal experience,
Councillor Perdue-Horan, this is a meeting where any member can attend. I have never refused any member who is not a member of this committee not to be able to speak. I'm sure, knowing the powers at Newark Hospital, they would have been more than helpful in changing the date for Councillor Darby to go and look round Newark Hospital. She would have been very welcome here today, and she would have been allowed to speak. And with regard to you saying that I had said she didn't speak, I didn't go to the briefing for the simple reason, as I've explained, the Vice Chairman and I had probably 6 hours at Newark Hospital. There was no need for me to come to the briefing here because we had seen it personally. It was made a comment that the other Newark member who was at that briefing did not appear to have a problem. No questions were asked at that meeting. These meetings are for questions to be asked in the same way as the meetings which the Integrated Care Board are arranging are there for people to come and ask questions. Now, I know how Newark Hospital works. We've had to alter a meeting at another hospital for one reason or another, nothing to do with us. But at the end of the day, Newark Hospital would have changed her appointment today, and she could have come here and she could have made her own comments, and I would have accepted her to speak. So please don't speak on her behalf, speak on your behalf. And if she wants to speak, she comes to the next meeting.
thank you, Madam Chairman. So basically, you were just passing on gossip earlier on, I take it. I'll carry on. I'll carry on with my point. And
I do not pass on gossip.
I will carry on.
Another member couldn't come today, and they contacted me at 7 o'clock this morning to say they were sorry they couldn't come. A Newark member. And I said, do you know if Councillor Darby's coming? And I was told they didn't know. So I said, does she have any problems, do you know? And I was told none were raised at that briefing. That is what these briefings are for. If people don't speak, either because they don't or they don't want to do, I'm sorry, that's tough.
Moving on, Councillor Eddie asked a similar question, and I'll just probe a bit further on that. You say you're open till 10 o'clock, and Councillor Eddie clarified that in actual fact, in reality, we're talking about 9:30, really, and I accept that. When people go to their shopping in the supermarkets, 10 o'clock means 10 o'clock, and they purchase their bread and milk right up to when the lady across the tannoy says that thank you for shopping, please make your way to the tills. That's 10 o'clock. Councillor Darby had cause to go to Newark Hospital recently, very recently, and rang up at 8:45. I believe it was a young member of a family that needed to go to be seen. And she was told it was fine, turn up. They arrived at 9:15. They were turned away.
I think that's an issue that
That might be a single issue.
Councillor Darby can raise that with Newark Hospital.
Madam Chairman, will you
She
please
can raise
allow
that.
me
She could have
to
been
make
here.
my case?
If it was so important, she should have been here today. She could raise that herself. You're not here to raise individual complaints for people.
Let me explain where I'm coming from. It is in black and white in this report that you are offering a service between 9 a.m. and 10 p.m. But in actual fact, and I admit I'm going on one particular case, that actually it's not going beyond 9:15 that I know of. And if you can assure members of the public that you are going to stick to the statutory 12 hours, people will accept, of course, that you may need an hour. Let's face it, you know, the managers of a local supermarket do not turn the keys in the door at 10 o'clock. They work extra. So if you are actually turning the keys at 10 o'clock, you're really closing to the public around about 9 o'clock. And I think it's important that we don't mislead the public. Madam Chairman, I hold you responsible, a share of responsibility for all the housing that's going on around Newark Hospital.
It's nothing to do with this today. Will you please?
And you are increasing the population of that area.
This is nothing to do with health scrutiny.
And the point I'm getting to here, is we have a situation where, in general, the message that has been got from the doorsteps that have been visited over the last 24 months from myself and my colleagues is that people in Newark, Coddington, Collingham, Winthorpe, all the villages surrounding there do feel that their service has gone down over the years and they feel let down. Thank you.
Thank you for that. But if Councillor Darby feels so strongly about that, she should have been here this morning. But Lucy, would you like to answer?
Yes, so a couple of things really, Councillor Purdy-Horan. I can hear from all of you today and how passionate you are all about ensuring that people like myself and my colleagues from the Integrated Care Board and my clinical colleagues sat behind me do absolutely everything we can to understand, recognise and the needs of the population, provide the best care. And I just want to say, on our behalf and on behalf of the many thousands of people who work in the NHS who aren't here, that is what we want to do. That is what we truly are as committed as you are to make happen. So please don't, I would hate you to go away with any sense that we don't share the same overarching objective as you do. And I can say personally, I visit this committee very regularly, and I never go away having not, rather than the double negative, I always go away having learned something I didn't know about how our patients are feeling about access to care, and we do our absolute level best to take all of that into the decisions that we make. And I think we have got a track record of proving that where there are overriding concerns and they do sit with what we can safely provide, we will change the way services are provided. So I do just want to, match my passion back with your passion. We want to do the right thing. That's why we're here today. In terms of the comment about the suggestion that the opening hours are less than are advertised, again, I can absolutely tell you categorically there is no intention by anybody to mislead. I think, and I couldn't quote, but I think in some of the briefings we did have people raise their experience is that on occasions patients have last been booked at 9. I can say categorically that we commission a service for 13 hours, and we do have that extra hour over and above the 12 hours to enable that kind of handover. We commission it for 13 hours. I'm absolutely convinced that Sherwood Forest hospitals use their best endeavours to provide that service for 13 hours. If we fail on occasions, please let us know. You can always let us know through our patient experience team. You can contact the trust. So again, it's not an intention to mislead. But I recognise that again, these are the things we need to tackle. So I think that's probably all I was going to say. We do want to carry on listening to you, and we will do, and we will come back and we will share with you what we've heard.
Comments.
Thank you, Madam Chairman. I want to sort of confine mine to the areas of the listening events. Obviously, Health Watch, our role is to listen to patients and people who use health and social care services. So I'm really pleased that you're calling it a listening exercise, that you want to hear what people think in the area around this proposal. So you've kind of given us the survey that you want to send out, and I've got quite a few issues with it, in the sense, and I think Councillor Wilmot mentioned the use of closed questions, and I agree. And I think if we're serious about really listening to the people of Newark and learning from the experiences when things changed several years ago and how important it is to local people, I think we need to ensure that the communications that we use, the language that we use is as clear as possible, because we've seen this morning just how complicated it is to understand the difference between emergency, urgent. You know, it's very, very difficult. So first of all, I'd just like to say I tried to fill it in as a member of Health Watch and I can't. So the first question is asking you, how are you responding to the survey? Well, I can't really answer those questions on behalf of people because that's my role. So I think you maybe need to think about two different surveys, one for individuals and one for organisations, to give their opinions differently. Also, I think if you're serious about listening, then you're given three options. Well, there's no option to give what people think might be the better opening hours, just what you've given them. So I think, again, we just, from a Health Watch perspective, we just want to ensure that people are being really listened to and given the opportunity to make their feelings clear. What I would say is the information that you put together in the document outlining the proposal, I think, is really helpful. I think given the issues around the change, how many more people have used emergency departments, etc., I think that's really helpful. So I think if you could look at the questionnaire again and just have a think of it from a perspective of somebody filling it in from those different stakeholder groups that you want to listen to, I think that would be helpful. I think in terms of the points that have been made this morning around 111, I know that we have it on our work programme and I know that will be discussed in the next agenda item. So I think that really highlights that there are serious concerns around 111 performance. So that again is on this committee's work programme. And also, I know Dr. Bartholomew mentioned and questions were asked about the GP booking systems. We've had that here at this committee in the past, and we've talked about how the ICB is supporting GPs to unify, if you like, the way in which people can access services. So again, that might be something that we want to hear back on in terms of progress around that. As we know, GP appointments is one of the biggest issues the public have. From a Health Watch perspective, it's probably the biggest thing that we get asked, and obviously being able to access appointments, yes, in terms of numbers and a bit availability, but it's often very much how you actually book one. So they were my main comments. We really are pleased that the ICB is looking to listen, and I think that's something that, again, just making sure that the questions you're asking, the information you want to receive back from people that you want to hear is not mapped out for them in a way that makes you only able to answer in a certain way. I think that would make everybody feel confident that you really are genuinely interested in listening.
I was just going to respond to one particular question, and I'm sure that we can do that. Sarah, and thank you very much for your thoughts. And the issue about the exact opening hours, that 13 hours, when do they work best for our population? That's one of the key conversations we want to have. So we need to make sure that is as easy as possible for people to be able to give as much rich data as they possibly can. So that is a very fair point. Yes, I think when you talk about your work programme around general practice, there's lots of things happening in general practice actually at the moment that it's probably hate to say this, overdue that we come back and talk to you. So, particularly around things like telephony access and cloud-based technology and all that sort of thing. So, very happy to do that. But thank you, and I guess Alex, you could pick up with Sarah, couldn't you? The specifics.
Yeah, certainly very happy, and thanks, Sarah. Very happy to pick those up, and we can certainly facilitate, a sort of organisational response from Healthwatch. That's very very straightforward. And I would just highlight the fact that the survey is one of the ways that we're gathering feedback. It's not the only way. So there will be plenty of opportunities through the public meetings, through individual attendance at events, for individuals and groups to be able to tell us completely freeform what they think and what they want. We have to put some kind of parameters and boundaries around it. Otherwise, we'll end up with a mass of kind of qualitative feedback, which is very hard to do anything meaningful with. I just want to remind colleagues that there's a whole spectrum of different ways for people to feed in, rather than just one kind of narrowly focused piece. Thank you.
More of the speakers wish to speak? Are you all happy? Have I any more questions from anybody, please? No?
Chair, I've just got one.
Oh, right. Sorry.
No, you're all right. I've just got one. And it's come, as I said earlier, my daughter is training to be a nurse, and most of her shift patterns are based around 12 hours. And on contrary to what some people have said, they do go over the time because they believe in what they're doing. But what I listen to quite a lot. Where did we get the 13 hours from? Because that's totally confused me in this day and age. That's all.
I think, yes, that's very good. But I think the 13 hours is the 12 hours is the national policy. And actually, by giving 13 hours, it allows for the sorts of things that Councillor Purdue-Horan has raised, that a patient might present at 9 or indeed 9:30 and want to have time for them to receive their care, because otherwise 12 hours becomes 11 hours, doesn't it? So I think that's one of our offers, is to continue. And staffing rotas are difficult, but our offer, both as a commissioner and as a provider, is to sustain that 13 hours to ensure that people can be can arrive and have their care started over that 12 hours.
So in that then, right,
yeah,
would be from listening to a lot of things that's gone off about age groups and getting to Newark, wouldn't we be better, and I hope they do, when they're looking at the consultation, wouldn't you be better extending the hours perhaps to something more like 14? It's just I don't know, because your shift pattern's got to be there, and it might give you that little flexibility for the community as well. I know it'd be a bit of a cost, but it gives you that flexibility for the community as well, that they know that they've got 2 hours instead of 13. It's just a suggestion. Thank you.
Yeah, and I think Alex said it earlier. Different urgent treatment centres in the county and surrounding counties open different hours. I think the one at London Road here is 7 till 7. People tend to come before work. We don't want the urgent treatment centre shouldn't be used as an alternative to general practice. So these are sort of things we want to hear from you. So I think the really important thing is what recognising that in that overnight period, we think urgent treatment is better provided in a different way. Which hours work for our population, and we want to hear. And we have no prejudice in our minds about what that kind of 12-hour plus opportunity to make sure that all the services can be properly arranged. We will hear what the population wants. I can't speak for Ben about how you staff your rotas, but you are staffing those 13 hours, aren't you? And if on an occasion we haven't, we would all apologise. That would never be a deliberate thing. That may have just been a staff sickness thing on the day.
Just to add, thank you. So the staff currently work a 13-hour shift, not a 12-hour shift, and that's sort of quite standard practice within nursing. So that's one of the reasons 13 hours, because the staff, that's a normal shift length, so that gives staff that ability to deliver that care. We do monitor if staff have to stay late, and that does occur occasionally if things happen, or and we monitor that, and that's occurring once or twice a month. People stay late because people turn up late in the evening, etc. Just two more things to respond to respond to Councillor Purdy-Horn's comments. So we haven't got it right all the time. We would like to hear from patients. If anyone has any complaints, there's a complaints procedure. They can come to us for that. We take it really seriously. We know there's always work to do. We know there's things to improve, and we also know that 98% of people are seen and sorted out within 4 hours. We know that most people resolve in the day. We know the number of transfers out of there hasn't changed in the past 5 years. And we also know that the patient satisfaction, people are concerned the service has gone down. The comments we get, the patient satisfaction results we get, don't suggest that, but if that's people's perception, that's people's perception. The number of complaints we have per month is less than I can count on one hand, but we always strive to do better, and we're happy for any feedback if individual patients want to approach us. So the only way we get better is by hearing that and learning. And the point of view of the car parking, I've had a response. It is early in the new year, they believe, to get it done. Don't know when.
Thank you very much. I'd just like to add a few comments before we look at the recommendation. I think this has been a very useful meeting this morning. A lot of points have been raised, which I'm sure the ICB will take away and consider. Namely, the overnight closures, which I think we always knew would be complicated, difficult, and add problems. But I can only impress upon residents of the area of Newark and Sherwood to make sure that they go to the briefings where they can ask questions in the same way as members have asked questions this morning, and also that they answer the survey, and that we don't come to November when you're looking at surveys and you say, well, I've only had 50 replies. I mean, that is of no use to you whatsoever. So I am asking all my 23 parishes to make sure that they go to one or other of the briefings and that they answer the survey, but preferably don't answer the survey before they know what is happening, I think, but that is up to them. So we have the closures, which clearly are highlighted as a concern. The Vice Chairman mentioned about our visit to Newark Hospital, and I think it was Councillor Bailey that mentioned retention. They did actually say to us when we were having a coffee, we met about 20 people in total. Alex had sorted them out to come from here, there, and everywhere. And they said they felt like a family. They didn't feel like the normal hospital. They actually felt like a family. And you could see that. It was very, very obvious that they're all quite close and all helping each other, which I think is a good thing. Now, the one thing that I think you haven't really mentioned very, very much are the 2,600 extra operations you hope to do, which I think is very important, because I know of several people within the Newark area who are waiting for operations, and I'm sure one of them has actually told me that she's waiting for the Newark hospital open to go in for a hip operation. So I think it's very important that is, as well as we dwell on the closure, I think it's important that we dwell on some of the positives of the whole thing, and the little wards at the side that can do small treatments. Two questions I have, which I've already had raised at a parish council. Will you be doing plasters there, arm plasters, that type of thing? Are you doing that? Because last night I was at a meeting. One lady said she was sent to King's Mill for a plaster to be put on her arm. Another lady said she'd had a plaster put on her arm. So the question is, will there be facilities for plaster? The other question I have is, if somebody has had an operation in the new theatre, or the other theatre for that matter, when they've had it, if they're not fit to go home that night, they will be kept on the sconce ward, presumably, or the Minster ward, or whichever. Yeah? You'll answer those questions in a minute. The meetings, I think you really need to advertise them. Headline page in the advertiser. But if you're going to give them the list that I've been given, without me sounding facetious, you've got a public meeting on the 14th of October, which runs from 10 in the morning to 11 at night. Do you really mean that?
Yeah.
Are you expecting that number of people?
Based on the volume of comments today, maybe. No, thank you. That's obviously an error.
I just thought before you put that in black and white, that probably ought to be changed.
That's a Saturday morning meeting, so we've really kind of worked hard to schedule these, some during the day, some in the evening, some at the weekend. But
and
we're not
anticipating
anticipating
you haven't yet given us logins, which I want to let people have what the connection is to those public meetings, which are virtual. So if you could ensure that I get the logins and probably all members so that they can pass that round. I intend, you've got about 14 meetings here. I intend to attend most of them so that when we come to discuss this further, I've heard firsthand complaints from people or concerns or probably praise. Let's hope. So I'm hoping to attend most of them, although I have got clashes of meetings when I can't. But thank you for organising these. It's giving the people of Newark and Sherwood, and particularly Newark, every opportunity to come and see what is happening, every opportunity to ask questions. And from what I see on our paperwork, this will be coming back to us about the 14th of November. Is that what you thought, Lucy? Because you mentioned
that might be slightly ambitious, but we can discuss that.
No, I think we'll.
I seem to remember that was mentioned when we were talking about extensions. It was a bit ambitious. So, could you have a word with Noel and get it sorted?
Yeah, and I think there's two things. We can come back in November because we will have finished consultation, and of course we'll come back. Whether we will have the fully evaluated feedback, including the clinical senate, at that point to make a recommendation, we may not. But very happy to be on your work programme for November, and we'll share where we are.
Thank you. So I think Ben was going to come back with two answers to my questions regarding plastering arms and something else I asked.
Thank you. Yeah, absolutely do plastering. There may be a small number of complicated plasters or people who need a manipulation than a plaster. So if you break something and it's moved a little bit, that may require a manipulation before the plaster goes on. So there are people that I sent across mainly because the manipulation requires some very senior to do it or requires a bit of sedation to do that manipulation safely or with comfort for the patient. But yeah, plastering, suturing, intravenous simple intravenous treatments, etc., all part of an urgent treatment centre specification. Regarding another question about people who have a day case operation who then need to stay overnight, it depends why they're staying overnight. So some people a small number of people react badly to anaesthetics, for example, and that would mean someone may need to be transferred to a centre where there's a bit more monitoring. If it's a more simple reason, they're feeling a bit groggy after it, that will be perfectly reasonable. Likewise, some people get slight complications, like they struggle to pass urine after the anaesthetic, for example. You might keep them overnight and make sure that's everything's working before they go home. So it depends on the reason as to why they
But there are the facilities.
There are facilities, but it does completely depend on the reason for that.
Thank you very much. Well, we'll look at the recommendations, but first of all, I really do want to thank you all for coming. I think it's probably a pre-run of what's going to come in the future with all your pre-briefs with residents, because clearly people do have issues, and it's something that has got to be addressed. But first of all, I'd like to thank you for coming back before December, which is what you actually said when we said please don't make it any longer, and you've come back with these proposals, good and bad, for people before Christmas. So on behalf of the committee members, I do thank you for that. And I thank you also for coming today. But let's have a look at the recommendation, which is on page 14. And I am actually going to take just a vote on this to make sure that everybody's probably singing from the same hymn sheet or not. And that is that we consider and comment on the proposals in respect of the opening hours of the Newark Urgent Treatment Centre and the provision of the out-of-hours urgent care services. I think we can say we've well and truly discussed that. That we work with local residents and stakeholders to publicise and ensure full participation in the engagement process running between the 4th of September and the 17th of October. I'm certainly doing that, and I'm assuming that the Newark members are doing that, and all other members who don't actually live in Newark but have people in Newark and go to your various parish meetings. There may be people who would like to make comments, so perhaps you would publicise that to them. And point number 3 is to consider the outcomes of the engagement process and the next step for the Newark Urgent Treatment Centre at a future committee meeting, which might slip, I've just been told, the date. You'll come back in November, so it won't slip. You'll make that promise. Okay, so do all members agree that we've covered this? Let's have a show of hands so that we all know where we are with it. Thank you. So that really does allow your consultation to go ahead now and all the briefings. Thank you very much to everybody. I think it's a good job we didn't put another item on the agenda today, because I don't think we would have got away at a reasonable time. Thank you to you all, and thank you to all the members of the. Yes, Michelle.
Councillor Saddington, I was just wondering whether we were going to look at the work programme.
Oh yeah. Yeah.
Just wait for them to.
We'll just wait for them to visitors to go. Not that we're rushing you.
Thank you.
Thank you very much.
Thank you.
Thank you. Lucy, I'll give you an email.
Thank you.
Thank you. Right, work programme, page 43. Did you have something to add, Michelle? Is there something you'd like?
That's not very good English, is it? The Nottingham County Council's annual report,
Yes.
22 to 23, which talks about the mental health support teams going into schools, which is a government-driven initiative, something I'm very, very actually supportive of. At the last check, there was 6 mental health support teams across Nottinghamshire going into schools, but that was only providing 30% of the provision that is needed. So I was just wondering if we could look at what is going on since then, because that's 65% of provision that isn't
being
provided, and it is a health service driven service. It's not delivered in-house by schools, it is delivered by a health service that goes into schools to provide that service.
Can you?
Is it commissioned by us, or is it a health service directly?
I'm not in. I know it's covered by the Health and Wellbeing Board.
Right.
I think it's one of those services that has a mixture of people involved in it.
We'll have a look at this and work out where it's best to go.
I would agree with you. I mean, I think what we will be told is that it will go to the Children and Young People Scrutiny, but we are here to do scrutiny on health. And I agree entirely.
I think it's overseen by the integration care, but that is my understanding of it. That's where it's done nationally from a government initiative, and that's where the money goes to. It's set up by them. They do the provision. Our Health and Wellbeing Board monitors it because we have some legal responsibility with regards to children's health and wellbeing, and it fits in our plan, if that makes sense.
Yeah.
So my understanding is why I've raised it today is it is a health service that is put into our schools and delivered into our schools.
I think we as a committee could spend time on looking at it, whereas if it comes within a committee with many other items, they can't give, to be fair, the time that this probably needs, because you've only to turn the television on every day to hear children who say they're suffering from one thing or the other. And I think mental health in children is on the rise, and I think it needs a very detailed look, and probably our committee, although it may not be seen to be, but I think it can be the committee that can spend the time on looking into it, whereas to have something so detailed in a children and young people's committee, or even health and well-being, I think would take a complete meeting. So we'll look into it. We can have a word with Councillor John Doddy as well and see what he thinks.
I just agree with what you're saying with regards to our capacity. I think as well the knowledge base here with regards to what people's knowledge are with regards to NHS and locality services. I think there's a greater knowledge within this committee.
I agree with you, and we have mentioned it on previous occasions, and I believe, I may be wrong, but Vice Chairman will correct me, I think if we were told it would go to children and young people, but I don't actually think, personally, this is my own personal opinion, that children and young people have got the time to look at it in such detail, because I think since the end of COVID and now, it has increased tremendously, and I think we need to get some kind of hold on it and see what is happening out there. So thank you for that. Anybody got anything?
Councillor Saddington, I will say, I don't think this is an officer-based decision. I think this is a two chairs getting together decision, because it doesn't naturally fall under each. It's more health than it is education. I do think this is a decision that you and your colleagues can make in scrutiny as a whole.
We'll take that into account. Have you made a note of it, Martin? And Councillor Wilmot wanted to comment, yes?
Thank you. On the 15th of July this year, we wrote to the Integrated Care Board to express concern about the pausing of the key project to deliver better health outcomes to the residents of Hucknall. After the pausing of the Cabell Centre, by the NHS, Lucy Dad actually wrote back to say that the Integrated Care Board will formally respond to the question that are within our gift to resolve. I wonder if it's possible we could invite Lucy and her team to a future meeting to discuss how we can get this critical project back onto on track.
Contact Lucy. I mean, she's been here this morning, but can we do that? And David.
Yeah, tomorrow's NUA programme was cancelled.
Sorry, Councillor Martin, can you put your microphone on?
Yeah, tomorrow's NUH.
Tomorrow's NUH, and it's listed on the 17th of October. I just wondered if we could have an update on what the plans are.
We'll ask them to come. I think there has been a pause because I don't understand. I think, yes, I agree. I think they need to come. There was a pause because the funding was transferred. If you recall, we heard that it was transferred to 5 hospitals that were in dire need of some funding. So they pulled the funding from Queen's. And no, it was not to do with the concrete. It was before that. But it might have been to do with concrete. I don't know. But concrete was not the mention of it. But they paused it to transfer money where they considered it was needed more importantly. And it is my understanding that there is a pause on the money. So there comes a limit as to how much they can keep doing. But that said, if you look at our agendas over the last couple of months, there have been sort of little things snooked in that are new, like a new Jubilee ward or a new ward at City. And I have sort of questioned if the money's been stopped, what's happening. So I think I agree with you. I think we sort of need an update on tomorrow's NUH, but I don't think it is at the moment as big as one might have thought a year ago. So you put that down, have you, as well?
Yeah, just to emphasise that the next meeting is a single issue item on NUH itself, not tomorrow's NUH, and Nancy May has been invited, so I hope she'll be able to come and we'll have a good discussion about NUH as a whole. But like I say, as the chair, Chair said, the tomorrow's NUH thing is on hold slightly, so that will be considered at a later date.
So that may slip, as Lucy used the words. But we'll see. We'll keep it up to date, and we will make a note of what Councillor Welsh has asked for. So thank you very much, everybody. Thank you for taking part this morning, and let's hope some good comes out of it one way or the other. And I think anybody that you know, anybody that you can influence needs to be asked to get on with filling in a survey. So thank you very much, everybody. Meeting is now closed.